Hello, good morning. I'm Ashok Kurokade, consultant rhinologist and anterior-skull-based surgeon from Winchester and the University Hospital Southampton, UK. I welcome colleagues from around the world on behalf of our organizing team to this inaugural Winter Global Rhinology Endoscopic Sinus and Anterior-skull-based surgery webathon. Global Rhinology Network is a registered non-profit organization with a mission to foster surgical education in rhinology and skull-based surgery. We have successfully hosted annual multi-center live surgical webcast, The Lioness, since 2014 in collaboration with Lion Foundation. Thousands of surgeons from all corners of the world have benefited from it. More than 2,000 surgeons from 110 countries have registered for GRACE 2020. We will have hugely informative and engaging sessions presented by eminent rhinologists and skull-based surgeons from around the world. GRACE 2020 is hosted at the Global Telemedicine Studio of Professor Wilco Groneman in Utrecht in Netherlands. It is supported by Medtronic and Karl Storz. Thank you.
Imagine, what if you could do even more to bring relief to your chronic rhinosinusitis patients with technology customized to your unique clinical and facility needs? Introducing Stealth Station Flex ENT Navigation System, a customizable system from Medtronic ENT, a market leader in image-guided surgery technology, featuring 6 hardware configurations, an optional portable card, 2 different electromagnetic emitter options, with flexibility in hardware design and optional software functionality. Get everything you need and nothing you don't with Stealth Station Flex ENT. Let's flex forward. Contact your Medtronic representative to customize a navigation solution that's right for you.
Professor Bradford, yes.
Yep.
Woodworth, Professor Woodworth is here, yes.
Yeah.
Let me introduce Professor Brad Woodworth, who has been at the University of Alabama since 2008. He is a nationally funded researcher investigating therapeutic interventions that enhance mucociliary clearance in both cystic fibrosis and chronic rhinosinusitis. Prof will be speaking on managing complications during endoscopic sinus surgery. Over to you, Prof.
Okay, can everyone hear me okay? All right. Ashok, thanks for inviting me as well as the GRN network. When I was asked to give this talk, it's about a half hour, so we decided to just focus on orbit and skull base. So we're going to focus on the major issues involved with that. These are my disclosures and research support. So orbital complications, we're going to talk about that first. And they come in a variety of issues here with endoscopic sinus surgery, primarily orbital hemorrhage, emphysema, optic nerve injury, extraocular muscle injury, orbital apex syndrome, nasolacrimal duct obstruction we're not going to talk about because it's a minor complication in my opinion. And then contralateral side, this often occurs on the contralateral side of the handus of the surgeon. If you look at over the years, orbital complication rates, back in 1979, Friedman and Kern said it was about 5 in every 1,000 intranasal ethmoidectomies. With endoscopic sinus surgery in the 90s, these were the reported rates. And, fortunately, I think the training has gotten better over the years. So there's less issues with complication rates. There was a recent study in 2020 looking at from 4 years in 2013 to 2017 in Japan, and over 70,000 cases with a reported rate of about 0.04%. And I think this is probably approximates what we see nowadays. It is important to note, though, that in the US in particular, there's a very litigious environment. And so there's a lot of legal liability in getting an iatrogenic orbital injury. Payments averaged about $1.13 million per case for a positive case. Diplopia was the most common medical complaint, and then permanent deficits and having to undergo additional surgery were present in 65% of these cases. So this is really an area that the best way to avoid orbital complications is to prevent them in the first place. The most common reasons for orbital violation: medial wall anomalies, unrecognized or just violated during surgery, intraoperative surgeon disorientation, and it's really, those landmarks are really critical to help avoid orbital injury. Scarring from previous surgery, as well as bleeding, which causes poor visualization, as Dr. Chen noted earlier. And again, prevention is really the key here. Preoperative common sense, making sure coagulation labs are okay, stop anticoagulation, antiplatelet medications. Review that CT. Really make sure you're checking for an atelectatic infundibulum, which is basically where your uncinet's going to be fused to your medial orbital wall. Look at the medial orbital wall, the erosion, the shape, location of anterior and posterior ethmoid arteries, as well as optic nerve. A paper by Eric Weitzel in UT San Antonio basically showed the preoperative sinus CT like this, avoiding a close call, as a mnemonic for looking at preoperative CT scans for surgical complications. This is something I did from I was trained to do as a routine four passes through the CT scan. This is a nice mnemonic to kind of look at all those potential surgical issues you could have. Cribriform plate, and that's going to be your depth, lamina papyracea, nodi cells, sphenoid, and ethmoid arteries. So way to avoid orbital complications, really the removal uncinate process is one of the biggest ways to injure the orbit. And we're going to show some examples of that. But the lamina papyracea dehiscence, unrecognized or not avoided during surgery, and then the anterior ethmoid artery getting it clipped and retracted, and then a nodi cell, exposed optic nerve is always a potential risk. So let's start with the removal of the uncinate process. There's varied attachments of the superior uncinate process to the lamina middle turbinate skull base. Several techniques have been described. There's the uncinate window with through-cut instruments, as well as just using a soft tissue shaver. A sickle knife approach. My preference by far is to use an uncinate window with through-cut instruments. I think it's the safest approach. There's major concerns sometimes, especially in a history of previous orbital decompression, for example, right here, where the uncinate is fused to that orbital, that decompressed fat. And then, of course, silent sinus syndrome, which is always a setup for an orbital injury. Prior orbital trauma can get in the way of the infundibulum, and so that's going to be a problem if you're entering into removing the uncinate to open the maxillary sinus. And again, that atelectatic infundibulum with the fused uncinate to the orbital wall is really important. And this technique of removing the uncinate process or pulling it away from the wall is really the preferred technique in this scenario. And if you don't, you can get such situations like this. And this is a 31-year-old female. She just had forehead pressure and was noted to have silent sinus here. And then she was transferred because she had an eye injury. And you can see where he got into the eye, trying to enter into the maxillary sinus. So this is the most common setup for a severe injury, including extraocular eye muscles, medial rectus, and getting into the eye with an orbital hematoma or subsequent other injury to the eye. So here's a scenario. Here's a silent sinus. The previous surgeon had actually entered into the sinus, and actually I was glad he didn't try and remove this. He tried to perforate a hole, was able to drain it, but the patient was still having problems with the natural drainage pathway, which was obstructed. And so to address this is my preferred technique. And you can see this is the area where they they had entered. But here's that unsnip fused to the medial orbital wall. Here I use the ball tip probe to pull the unsnit away from the orbit. And what that's going to do is create space for me to remove the unsnit with a 90-degree forceps. And then I have space between the infundibulum, the remainder of the unsnit, the infundibulum, and the medial orbital wall. And we're able to look into that area and make sure that that area is completely contiguous. If you had tried to do an unsnit dissection using a sickle knife or other sharp instrument, you can penetrate the globe in that scenario. Lamina pepratia dehiscences are common. Sometimes they're congenital, like in this situation, but they can create a setup when you're skeletonizing the ethmoid cavity. Anterior ethmoid artery is often on a pedicle, and this should always be identified preoperatively on the CT scan. Up to 40% are dehiscent along the skull base, and they're often located on the pre-op scan at the junction of the superior oblique and the medial rectus muscles. Kennedy also liked to refer to this as Kennedy's nipple. Here's the anterior ethmoid artery again, just intraoperatively. You can see it across the skull base, and we can avoid it in this scenario. The anode cell, sphenoethmoidal cell, most posterior ethmoid cell. The optic nerve is generally exposed or in the anode cell. Often need to fraction down into the sphenoid or move with a true cut forceps. And just recognition is really the key in this scenario. And you can see an optic nerve that's dehiscent with no bone over it in this scenario. And here's the patient after we operated on him. But I've taken down that little ridge, left a little bit of ridge there, but there's the optic nerve coming across there. So avoidance intraoperatively, hypotensive anesthesia, making sure you have good blood pressure control and lack of bleeding. That controlled infundibular incision with a deeper lateral will actually penetrate the orbit, so you really want to improve and mobilize that unsnit away from the orbit. Early identification of the orbit, and then we leave the eyes exposed during surgery. I generally use tegaderms, but you can use tape, but it's important not to wrap the eyes with a blue towel or anything, and so you can continuously inspect or gentle palpation on the globe if there's any concerns. Early detection is key. Fat exposure can happen. You want to terminate the dissection in the region. Microdebriders, man, they can remove fat and muscle very fast. There's many instances where people have removed like the entire medial rectus, for example. Do not manipulate or remove that fat. Don't use monopodal cautery. They can get a lot of jump currents. Use some bipolar if you need to. Make sure there's no medial rectus or muscle in the area. And then minimize nasal packing in that scenario. Try and avoid nose blowing and sneezing because they will inject air into the eye and get a pneumo orbit. Here's a fat exposure. Everyone is familiar with that, and they're going to talk about medial orbital wall decompressions later. For management of retroorbital hematoma, and so these are always this is the scary scenario of sinus surgery. And so this is where the globe compliance is decreased. You can get proptosis, lid edema, eyelid ecchymoses, and really get that increased intraocular pressure. Afferent pupillary defect can happen when that pressure overwhelms the perfusion pressure from the ophthalmic artery and central retinal artery. If you get a pale retina, you definitely have central retinal artery compression. Of course, ophthalmology can identify this by looking in the eye. Timing is important. So sometimes there's a slow onset, and that's usually a small capillary type issue. And then there's a sudden onset with anterior posterior ethmoid artery. It's usually arterial bleed into the eye. Relative afferent pupillary defect, important to know how to recognize this. And this is, for example, the right and left eye. And what you would do is shine a light if the defect's on the left eye, if you shine the light in the right eye, that will constrict. But then when you shine it in the left, the other side doesn't constrict. And then you go back and you get a paradoxical constriction. And so that's going to be a defect in the left eye, and that's going to be RPD or RAPD. This is something ophthalmologists are always looking for. In terms of management, you want to control that epistaxis. Topical timolol or any sort of drop to lower pressure is important. You can give acetazolamide by IV, where this decreases aqueous humor production. Does have a slow onset. Mannitol is probably the preferred agent, but given both is fine. Steroids, of course, to decrease pressure and inflammation as well. Ophthalmology consult, very important if this happens intraoperatively. Get an ASAP page into ophthalmology so they can come to the area. If you have a tonopen, that's very useful. You want to measure the proptosis intraocular pressure. Tonopens, so this is important. So they are inaccurate over 30 millimeters of mercury. So generally, the rule of thumb is when it's greater than 30 millimeters of mercury, you do a decompression, like a lateral canthotomy and cantholysis. The eye can live at like 40 millimeters of mercury for a while. But the problem is again, if you have a tonopen and that's how you're measuring it, you really don't know how high that pressure is going. And so that's where these numbers come from. Don't do any attempt to aspirate a hematoma. Remove any nasal packs that are present. And again, that canthotomy and cantholysis comes in handy. It's useful to know how to do that. And if you're in a course or anything, you should try and practice on cadaver heads during a sinus course. Medial orbital wall decompression will relieve the pressure. And so this is an option, especially if they're already in the operating room under anesthesia. And you can actually do an orbital floor decompression as well in a pinch. And all these things will help lower that pressure and get the pressure off the nerve. So lateral canthotomy and cantholysis, which you see here, there's a canthotomy pinching laterally and disrupting the tendon. But that inferior cantholysis really gets you much better pressure. So you decrease the pressure by about 14 to 19 millimeters of mercury versus 30 by doing this inferior cantholysis. You can actually do a superior cantholysis too and get some more pressure release as well. But this is the standard technique that we use. Important note, you can get hematomas from any means. This is a patient who went blind after getting hematoma because a balloon was placed into the orbit. Surgeon thought they were in the maxillary sinus and basically inflated the balloon inside the orbital compartment and created an orbital hematoma. And this is also important because, in areas where you have high allergic fungal sinusitis, saline is often used to debride or hydrodebride sinuses. And I put this here because this actually happened to me. Not a hydrodebrider, but just to note that this was noted as using a hydrodebrider in the past as an adverse event. And I know that Jim Palmer had an episode of this when he was a fellow, but I was flushing out AFS and from the frontal sinus, and the suction went into the orbit. And so when I flushed about 60 cc's, it actually went into orbital compartment. And I actually had to do a lateral cantholysis in that scenario to decompress the pressure because he actually woke up not seeing out of that eye. So you have about 60 minutes in that scenario if you have no light perception to decrease the pressure. So you got to do it quickly, and you had a full recovery, but it was one of the scary situations for me. So this is something I always like to say in terms of orbital complications can cause a major issue. Extraocular muscle injury is also a major issue, and this typically happens with powered instrumentation. It can happen in prior orbital trauma. Most common is the medial rectus, but there's been instances of superior oblique, inferior rectus, and I'll show you a really disastrous case where they nucleated the patient as well. Forced suction is a technique to check out if the eye muscles are entrapped. If there's viable muscle found, you can repair by ophthalmology. This rarely works, but I'm going to show you a technique that my oculoplastic surgeon is very good at and published on. And if it's not detected until post-op, early exploration repair certainly is indicated, but there's some later things that can be done. So this is a 47-year-old male. He's had endoscopic sinus surgery, and the post-op finding, what you see here is an exotropia. The eye is exiting to the left side, and here if he tries to look to the right, the eye is still in position, and that's because the medial rectus has been severed. And what you can see here is that this was taken care of with a debrider. So a debrider essentially removed, this is optic nerve right here, essentially removed the entire medial rectus. And there's a little bit of muscle at the insertion we'll show you, but this is a terrible complication. And so he does a fasciolateral graft fixation. The traditional problem of using any sort of graft or trying to fixate the eye in a medium position is that you really don't get much rotation. About 90% of diplopia or vision is actually in the straight or looking down. And if your eye is migrating to the laterally, you will have diplopia. And so this scenario will bring the eye back into position and allow even some downward and upward rotation. And so he uses a fasciolatograft and finds the insertion of the medial rectus. And then we'll place a graft that's going to be pedicled back in the periosteum posteriorly in the orbital wall. And then we'll basically attach it to the insertion of the medial rectus and then tighten it, and so that eye is looking straight on and in opposition to the other eye. In this scenario, you can actually get tiny little bit of movement here, but more importantly, you can get up and down movement, which is excellent because 90% of the time you won't have diplopia in this scenario, so it's an excellent technique to try and fix that. For other disastrous things like blindness, this can happen from pharmacology, like injection or local epinephrine that gets into the orbital compartment, or cocaine. Injections have known to do this, as well as the orbit compartment syndrome from the retroorbital hemorrhage. Optic nerve transections are very rare, but early on the endoscopic sinus surgery experience, this was a physician's wife who a surgeon basically transected both optic nerves. This was Dr. Kennedy's case. The patient was sent to Dr. Kennedy to see if anything could be done about this, but of course nothing was able to be done. Optic nerve transection, projection of the optic nerve, 3% in the posterior ethmoid, 23% sphenoid, but as we mentioned, that sphenoethmoidal cell is really important. This is a disastrous complication of endoscopic sinus surgery. This patient didn't even have preoperative sinus disease. And in this scenario, the surgeon noted that she saw abnormal looking polyps while opening the maxillary sinus and was shaving those down, and then noticed that the eye was sinking back. And that entire orbital compartment was sucked up into the debridor. And so anything like this is just an absolute disaster, but trying to avoid getting completely lost is one way that can happen. As far as skull base complications, you want to avoid the low skull base. Identify skull base dehiscences. Short posterior ethmoid sinus is a setup, and then dehiscent carotid artery and carotid artery injury is important. I've actually dealt with 3 carotid artery injuries shipped in from out of town during endoscopic sinus surgery, and generally all 3 of them occurred when people were popping into the sphenoid sinus with a suction. It's important to go through the natural ostia to avoid that injury. Ethmoid roof configurations, everyone's familiar with these, but bottom line is you're looking for a depth in the olfactory fossa, because as you migrate, especially for a right-handed surgeon, they will, and on the right side, this tends to be the most common spot for getting an issue. The level of cribriform is important, and asymmetry is also important, because recognize that on both sides and make sure you identify that on the preoperative CT scan. Skull base dehiscence can happen for a variety of reasons. We have lots of allergic fungal sinusitis down in the southeastern United States, and skull base dehiscence is generally present in most of these cases. Nothing needs to be done about these to repair them. They don't leak unless you create a leak, but you got to recognize it ahead of time and avoid those areas. The short posterior ethmoid is the classic setup, and what you have like a 3:1 ratio here to the posterior ethmoid on the coronal CT scan. This really occurs because you're going through the basal lamella. So in this case, on the right, with a normal basal lamella, where you enter in that vertical portion, you're kept in a good position. Whereas in this scenario, you've got a very elongated horizontal portion, and then the vertical portion is very small. And so if it's not recognized ahead of time, you're very close to skull base, and that's when leaks can happen, like in this scenario. And this is because that short posterior ethmoid, they didn't realize where they were, and they went in too high and created a leak. And as I mentioned, the dehiscent carotid artery is a thing you need to avoid. In these scenarios, you can imagine if you're poking through the sphenoid sinus and you're not doing a nice controlled opening, you can get right into a sphenoid sinus, especially if it's dehiscent, and create a pseudoaneurysm, massive hemorrhage, and create a major issue. So this is generally the situation that occurs. And so for me as an academic rhinologist, I've about a dozen times over the last 13 years, I've had ENTs page me and just say, like, I'm in the OR right now, I got a CSF leak, what do I do? And there's really two options in this scenario, right? So if you don't feel comfortable, you can pack the cavity, wake the patient up, and transfer to a tertiary rhinologist or hospital. But sometimes I could walk him or her through a simple overlay graft repair and keep them overnight with CSF leak precautions. I always get a CT to head in AM and then follow up in my clinic as an outpatient if there's no leak. And this scenario has been very successful. I think anytime an ENT has called me and I've discussed this with them, they've been able to just kind of take care of it. But it's important to be comfortable in that scenario. And so it's really like, what are the risks of more surgery to close, and what's the chance of also spontaneous healing? My preference is to fix these anytime, but it is noted that in traumatic defects, they're often small, a crack or series of cracks, but the spontaneous closure rate is quite high. These are low pressure type leaks, and they can seal up. In iatrogenic leaks, the rate of spontaneous closure is expected to be lower. The defect can be larger. You can have small cracks, or like you get eggshelling, and so that's where obviously you can get a lot of bone moved with a powered instrumentation, but often it starts as a small little crack by the cribriform and then can kind of eggshell and get bigger. And these patients also have sinus disease and infection around, and so the risk of ascending meningitis is probably higher in these scenarios. So it's an intraoperative CSF leak, and so what do you do? And so my recommendation, if this happens to you, is to just kind of stop, reassess where you are in the ethmoid cavity. This is generally where it happens. You want to improve your visualization. Pack the cavity, use your pledgets, raise the head of the bed, that decreases CSF flow, wait a few minutes, kind of get hemostasis and regain your composure, and then go back and review that CT scan. Try and reorient yourself. Remove the packs and clean up around the area. Again, reorient yourself and go back to basic landmarks. Find the medial orbital wall, find skull base and sphenoid. If you're totally lost, then the wisdom of continuing the surgery really could be questioned in this scenario. You can potentially get major issues if you try and repair it and you really don't know where you are. If you make a decision to repair the leak, you want to use bipolar ablation, cauterize mucosa around the defect. It's important not to get fancy. I mean, unless you're doing this all the time, getting a fancy repair here is probably not the best choice. Simple repairs are best. You can turn a small defect into a large one if you try and do something fancy. Use a supportive pack, to help the repair sit, and then monitor overnight with neurochecks. Get a CT of the head in the morning. Use IV Vorcephin, things that penetrate the spinal fluid. Make sure they don't get meningitis. So, this is a situation where it was what not to do. So this is a 50-year-old female in outpatient sinus surgery. The surgeon discloses an intraoperative CSF leak, and then says, it's okay since I repaired it, you can go home. And so what happened was 24 hours later, she shows up in our ER with meningitis and a 3-centimeter cerebral hematoma. The entire cribriform plate essentially was removed as part of the repair. And when I went into endoscopically to fix it, there was a large cartilage graft that was hanging out on the floor of the nose. And so what this ENT had done was he probably started with a small defect, but then tried to get fancy and put a cartilage graft in. And of course, it's very difficult to put an underlay graft in the cribriform area in the first place. And so he ended up making a much larger defect that included the cribriform plate, shoved the cartilage graft up there, obviously got a cerebral hematoma, and the patient ended up having a really hard time. And we got it fixed and all that, but this is a scenario which is clear, against the standard of care. always keep the patient overnight. There's no reason to send them home in this scenario. You know, you've got to play it by the book. Image-guided surgery, this is important, a word of caution. It does add a certain level of comfort, and image guidance to powered instrumentation, in my impression, is really bad, because it allows people to look at the image guidance, and if they're off by a couple of millimeters and they're using image guidance, they could be sucking in medial rectus before they even know it. And so you never completely trust the system. That's what I always tell the residents. Always just use it to confirm what you already know, and it's not a replacement for surgical experience. I had a local ENT who called me up for the same scenario where he got an intraoperative leak, and he was cursing himself because he was like, you know what, if I didn't have image guidance, I wouldn't have gotten this leak. He thought there was one small cell, and the image guidance told him there was one small cell behind where he was, and under normal circumstances never would have tried to penetrate that area. And the image guidance in that scenario actually was an instrument to cause the leak. So surgical principles for these, again, just precise localization of the leak site. You want to meticulously prepare the recipient bed and accurate placement of an appropriate graft. And so this is what I would recommend. This is the scenario where a 55-year-old male was transferred for iatrogenic CSF leak. It's going to be, it's going to be a very messy area with a lot of blood around it. And the key is just to kind of get hemostasis, clean up around the area. Notice I went back, found skull base, started skeletonizing forward. Now I'm using a coblator. It's a bipolar and coblation instrument, and there's some brain that's kind of herniating through. And so what I'm doing is just cleaning that up. And it's important just to use a hemostatic instruments to try and clean this area up. You want to remove the mucosa around the defect. And once you removed all the mucosa and cleaned it up with the coblator, you've got a very safe field. Is going to be very unlikely to have a cerebral hematoma in this scenario. You can just do a little biodesign graft. This is a biodesign graft. Other graft materials are fine. You can use a mucosal overlay graft if you're not comfortable with other graft materials. Here I just did a little double layer repair. Not really much need for bone in this scenario. I usually only use bone in high pressure leak situations. These usually heal just fine through reincorporation of scar tissue and mucosa. And then a good supportive gel foam and a pack underneath to help from coughing and pressure. This is a spacer that I inflate. It's surrounded by a gloved finger. It's a standard technique I use in CSF leak repair because it provides a nice balance against the coughing and intracranial pressure forces after surgery. And you can have some dramatic ones like this where they tried to open up the frontal sinus with a drill and drilled into the frontal sinus. In this scenario, this is a more complicated repair, but I like flaps in some of these scenarios. This lady was also a little heavy, and so I was concerned about intracranial pressure. And so I used a posteriorly based flap pedicled on an anterior ethmoid artery in this scenario. And then we drill out in a draft 2B to gain exposure. I make sure that the area is nice and open. What I'm going to do here is just reduce that area, make sure it's nice and flush. This is the posterior table of the frontal sinus here, and we get it down to our defect. Again, this lady was kind of heavy, so I wanted to make sure there was a little bone graft in there as well. Here I'm going to put a biodesign graft in a epidural space, a little bone graft. And then we'll flip up this flap to cover that area. You'll want to make sure that bone is covered. Use flaps and grafts for bone around any exposed bone around the area as well. And then again, supportive packing is also important. Here I place a little Eviseal and a frontal sinus elastic stent. And there's a little bolster that we use as well sometimes. So here's the frontal sinus nice and open at the end of the case, about a year later. And reconstitution of the defect. So in conclusion, the best correction for surgical complications is never get it in the first place. Prevention is key. Manage complications by the book. Don't be cavalier about it. I mean, there's severe issues that can occur, and you know, it not only opens you up to legal liability, but you know, you want to do the best for your patient and make sure that you can do everything you can to avoid a disastrous complication. And don't get fancy with that CSF leak repair. Do something simple in these scenarios. They're typically low pressure leaks. And go through those steps that I talked about earlier to make sure that you don't end up with a major problem. So thank you. I'll take any questions now.
Stealth Station ENT, the advanced image guidance system for the full range of navigated ENT procedures. Engineered with you in mind, based on decades of scientific, clinical, and engineering expertise. We're expanding what was previously possible with image-guided surgery. Flexible and elegantly designed, Stealth Station ENT streamlines the workflow so you can maintain focus. The flat, under-the-head emitter allows for an efficient setup. Its design allows for a large EM field. Easily find your patient's exam through a variety of network options, super speed USB or optical disc. The visualization and modeling features give you the perspective you need. Leverage data from multiple sources to create high-resolution 3D images. View structures and pathology with high fidelity. Registration expertly matches the three-dimensional positioning of the patient with the preoperative images used for navigation. Patient registration combines registration methods and provides numerical and visual accuracy feedback. Leverage the latest technology for advanced surgeries. See more, do more. The result? You have an image-guided perspective like never before. With Stealth Station ENT, you're at the forefront of ENT surgery. You are Stealth.
Thank you so much, Prof. I think your last slide is critical for all of us, you know, in that we need to know one's limits and have a clear ceiling of comfortable intervention. And beyond that, pick the phone up, get help.
That's right.
In your opinion, what is the most common reason for intraoperative complications occurring?
Yeah, it's getting lost 100% of the time. That's, I don't say 100% of the time, let's just say 99% of the time, it's because someone's lost. I mean, no one ever intentionally wants to do an orbital injury. And so losing landmarks, you know, I mentioned that over-reliance on image guidance, that can be a big setup as well. You have to make sure that you know exactly where you are at all times. Always double check things. You know, image guidance is useful, but it's really just there to confirm where you are and where you think you are, and making sure you're always readjusting and looking at things. Wolfgang Draff was I got a chance to meet him when I was a rhinology fellow at Penn, and in that picture that Jim Palmer showed earlier, I was at that meeting and I got a chance to talk to him, and he told me something I never forget. Even though, like, you know, look, we've all experienced rhinologists, we've all done thousands and thousands of these procedures, we get very comfortable. And Wolfgang said, like, you get complications when you get too comfortable. And so he used to say that in the back of his head, he always told himself, sinus surgery is hard, sinus surgery is hard, sinus surgery is hard, over and over again when he felt he was getting too confident. And and at the time I was like, wow, this major rhinologist, you know, world famous rhinologist still says that to himself. And I took that to heart. Like, I do that still to this day. I tell my residents, you know, you never want to get too comfortable. If I feel like I'm getting too comfortable, in the back of my head, I just repeat what Wolfgang Draff said. And it helps keep you, like, safe and always checking your landmarks and making sure where you are.
I'm glad you mentioned caution when using thermal energy generating instruments near the skull base. Now, if you were using, say, a suction monopolar, what energy setting would you have it on, especially when you're near the skull base?
Yeah, so anytime if I was going to use a monopolar, I'll go to 20 or below. And so I had there was a private ENT who called me and he had it on 40, and he was cauterizing the anterior ethmoid, and it got a snap, crackle, pop and got a CSF leak. And I was telling him, Alex Chu, well, I'm not throwing Alex Chu under the bus. I mean, he's awesome. But when I was a fellow, he was in the other room, and he comes in and he's like, "Oh man, I got my first CSF leak," and he was like all mad, and he did it because he was in a hurry and he was using a monopolar, and he was using it on 40, and it went snap, crackle, pop, and it caused a leak right in I think it was right in the area of the posterior ethmoid or somewhere around there. And so low thermal energy or bipolar, I think is much better. I really like the coblator. It's an excellent instrument for working around the skull base and the eye.
I totally agree. I think with the coblator, with it generating less than 90 degrees Celsius, it's much more gentle, to say the least, really, to the skull base, really. I was really glad to see the two options that you would offer on your ASAP ENT page. Because I've done similar as well in terms of trying to walk through a very distraught colleague at the end of the phone.
Right.
And actually, it's a great way of supporting our colleagues. And if the repair, and it's regardless whether the repair is successful or not, it just empowers them. And it just reaffirms that they've done the right thing of de-scrubbing, taking a breath or two, swear a little bit, and then pick the phone up and call someone for help. And certainly I've done that myself, walked away and then shouted at the wall, and then obviously did something better after that. But thank you so much. I'm going to open up the final bit here, which is the Q&A. And it's with regards to CSF leaks. Question number one, do you put underlay grafts?
Yeah, so I do personally. If it's big enough, right? So if it's a real small crack, you can just do an overlay. I mean, and I'm giving a talk on CSF leaks and skull base reconstruction tomorrow, the different types and everything. But simple leaks, traumatic leaks, they do fine with just a simple overlay. And that was my point here is like, usually these patients are just normal sinus surgery patients. And if it happens to you, it's going to be a low pressure situation. They're not unlikely to have elevated ICPs and all that. All you typically need is just to clean up around the defect, not make the defect bigger, and do like a simple overlay, either mucosal graft or some other graft you feel comfortable with. Place it over the defect, put some gel foam or nasopore or whatever you want underneath. I like that removable rubber spacer because it inflates nicely and it kind of keeps it solid underneath. And then you counteract that pressure from the even though it's low pressure, but you counteract them coughing and stuff afterwards. Again, you keep them just some bed rest overnight, monitor them, make sure they're okay. And usually they're fine, like you move the spacer or packing a week or 2 weeks later, depending on what your preference is. And most of the time they're going to do fine in that scenario. There are other ones that I would recommend definitely an underlay graft, but in those scenarios, that's what you should do. Totally
agree. Final question. And I'm going to have to rephrase this, I think. But I think what the gentleman's asking is, would an iatrogenic CSF leak heal conservatively?
Yeah, so, and that was one of my points about, we do, like for traumatic leaks, for example, from MVAs and that kind of thing, there is a lot of conservative management. You could make the argument that, every traumatic leak should be fixed and whatnot. And certainly I think real large comminuted ones should be fixed. Bernal Spreckelson discussed that a risk of ascending meningitis and 30% of people managed conservatively and traumatic leaks and stuff. And so there's certainly an issue with potential of ascending meningitis if you get fusion of dura to mucosa and that kind of thing. So, in iatrogenic leaks, my basic opinion is usually to try and repair them all. If they're really small and like they're recognized post-op, like for example, a little bit of intracranial air or something, and you can't really even identify a crack, there may be a situation where you could do like a little conservative management with bed rest. But my opinion though, these are typically sinus surgery patients. They've got some infection around the field. It's better just to go ahead and repair it. Maybe basically eliminate that risk of meningitis in the long term.